Good morning. It's a great pleasure this morning to present Dr. Naomi Haas, who's visiting us to give the grand rounds this morning, and she'll also be giving the urology grand rounds tomorrow morning. For those who are interested, it'll be also in this room. Dr. Haas is at the Abramson Cancer Center at University of Pennsylvania, Division of Hematology Oncology. She's an associate professor of medicine. She's in the genitourinary malignancies program. Dr. Haas got her MD degree from Northeastern Ohio Medical University and did her fellowship at Fox Chase and did postdoctoral NIH training and KO8 grant fellowship at Fox Chase. And then at University of Pennsylvania, she became a member of the division and continued her leadership activities. She's published numerous papers on GU malignancies, and she's very active in ECOG and in worldwide reputation in the area of GU malignancies. And she has many grants, NIH and other grants supporting her research. She's the director of the prostate and kidney cancer program. We're very pleased to have Dr. Haas this morning here to present us kidney cancer treatments, bedside to bench experiences. Dr. Haas.
Thank you. This is my first time to Emory, and I've been to Atlanta before, but it's really good to come and visit, and I'm very grateful that I was given the opportunity to present some things. Here are my disclosures. Most of these are to support clinical trials. And I just want to kind of put the context for the fellows here as far as, you guys really have a wealth of drugs these days to treat patients with. And back when I was a fellow, we really didn't have anything. We had, we used chemotherapy and we used interferon for treating renal cell. I remember treating patients with vinblastine and with gemcitabine pretty commonly, and 5-FU for renal cell cancer. We didn't use chemotherapy back then for prostate cancer. We used hormone therapy, and we thought that maybe and Taxotere and Taxol were being developed. I'm ashamed to say this when I was a fellow. So the world has really changed, but you can see that there's really a wealth of agents now that we have for treating kidney cancer. And but if you look at it, there's really just three general areas that most of our druggable treatments are focused in. One is in the area of metabolism. The other is anti-angiogenesis, and then the third, hot area now is full swing back to immunology. So, I think that the take-home message here is really these are the three mechanisms that we use, and we're still not curing kidney cancer in most patients. And so I think that we think that it's very exciting right now with a lot of these new immuno-oncology medicines, but I still don't think that we've gotten to the bottom of kind of teasing apart how to cure kidney cancer. So when I was a junior faculty, I had some great opportunities presented to me, and one of them was the development of the VEGF inhibitors, which of course are very effective in kidney cancer. And this activity in kidney cancer back in the early 2000s made us all really, really excited. We were going to cure kidney cancer. And for me, the opportunity was to look at these drugs in the adjuvant setting, and I really owe a lot of my career to ECOG because I was able to write a phase 3 trial in ECOG to look at the activity of sorafenib and sunitinib in the adjuvant setting. And so the current standard of care in primary renal cell to this day is still resection and close observation. But as you all are aware, there's been a lot of activity in the last year with trials reporting out. So I'm going to revisit some of the work that I've done and put it in context of the potential that you can use these trials to leverage basically using trials, whether they're positive or negative, and then being able to go back and mine the data. And that, to me, is a really important strategy when you design a clinical trial. So the trial that I led that was a phase 3 was the ASSURE trial, and this was presented at GU ASCO in 2015 and published last year. And this trial enrolled both clear cell and non-clear cell non-metastatic kidney cancer, and we included patients who had some risk of recurrence, which we would classify kind of as intermediate, T1B, high grade, NNE, all the way up to N1 disease. And patients were allowed to enter the trial before they had surgery because we were hoping that we would collect samples. As it was, only about 50 patients, I think, enrolled at that point. But following surgery, we had great enrollment, and patients were stratified by their risk, by histology, so clear cell or non-clear cell, ECOG performance status, and also by surgical approach. This was Ed Messing's idea to look at this and see if this played a role. And then patients were randomized within 12 weeks of surgery to either get a year of sunitinib at full dose, 50 milligrams, 4 weeks on, 2 weeks off for a year, or sorafenib, 400 milligrams twice daily for a year, or placebo. So all of these patients took about, I think it was 8 pills a day. They took their pills, and then they took the other pills that were placebo-controlled. So they took pills that said both sorafenib and also sunitinib, and they didn't know what they were taking. But if you look back, I mean, that's a tremendous challenge in and of itself, just to make sure that patients take that many pills every day and stuff. And accrual went very, very well. It was, slow to begin with, and then but it was the only adjuvant trial out there, and it was brisk. But we noticed that there was a large number of patients that were dropping out for toxicity and intolerability. And so protocol was eventually revised, and we thought about this. We had many meetings about this, but we ended up trying to start patients at a lower dose. So the starting dose was lowered to 37.5 of sunitinib. And sorafenib, the starting dose was 400 milligrams per day. And you could scratch your head a little bit about that also, because I think a lot of people use 600 milligrams of sorafenib, but that was what the company wanted, and so that's what we did. And our primary hypothesis in this trial was, could either of these drugs increase disease-free survival in the adjuvant setting? So that was our primary endpoint. And we developed the statistics based on the UCLA International Staging Criteria, which predicted that patients that had this sort of intermediate risk category should have a 5-year relapse-free survival of about 62%. And if they were very high risk, it would be about 40% over 5 years. And this was the proportion of patients that we anticipated would enroll on the trial. And so we were predicting that the drugs would decrease the DFS by about 25%, and that we would be able to see this in a study of about 1,200 patients or so. And then when we realized that there was a lot of dropout, we of course had to replace a lot of patients, so we enrolled another 600 patients at the time that the study was modified to have a lower starting dose. And the arms were very well balanced. You can see, as is true in kidney cancer, there are more men than women that get kidney cancer. We did not do very well in this trial as far as accrual to minorities, and that's something that I think we continue to struggle with all clinical trials. And you can see that the median age was actually slightly lower than I think what you generally see for onset of kidney cancer. Close, but slightly lower. And patients in general were pretty healthy. And then as far as histology, pretty much fits the curve. 80% of patients with kidney cancer are clear cell. It was powered to clear cell. We had the largest collection, though, of chromophobe tumors in this population, and we had a fair number of patients with papillary, both type 1 and type 2 enrolled. We did not allow collecting duct tumor, but we did allow unclassified, and we did collect information about the number of patients with sarcomatoid features. So very disappointingly, we did not see any improvement in DFS. The median for Sutent was 5.8 years, sorafenib 5.8 years, and the placebo was 6 years. So the hazard ratio was really a very impressive 1. And the overall survival, this has been updated, but we continue to not see an improvement in overall survival also in this trial. So we did see a lot of toxicity, and there's a lot of discussion about, well, do these people get more toxicity because they're more active, or do they get more toxicity because these drugs really aren't having anything to target? They're just targeting normal cells because you've removed the tumor. And I think that we're going to have to keep an eye on this as well with immuno-oncology, and whether we see more side effects in these drugs. But I do think that it has to do with the fact that people on adjuvant therapy don't have a lot of tolerance for side effects. They're supposed to be, well, you're kind of talking them into something they're not planning to do to begin with. But I also think that there may be a role for just sort of more off-target effects because there's nothing that the tumor is targeting, so you're treating well patients and you're making them feel kind of sick. So we did see about a 60% incidence of grade 3/4 toxicity. And interestingly, we did see some also in the placebo group, and we think that some of that is was disease recurrence and symptom, or that's what we're postulating. So was there a liability from anti-angiogenic therapy? This is our statistician Judy Manola at ECOG was very reluctant to do this, but we asked her to basically do a post hoc landmark analysis. So this was time 0 was when they came off of drug. And we did not feel that this was statistically significant, or I should say, so there is a little bit of separation in the curves, but they do come back together here. And I think that, one of the things that kept me up at night was after Bob Kerbel came out with data looking at Sunitinib in mouse experiments in which he treated mice neoadjuvantly and also adjuvantly after tumor implants. And it looked as if, in some cases, it was making the tumor act worse rather than better. I worried, because that data came out right as this trial started to enroll, that we were going to have people do much worse on the active treatment arms. But that was the case. Was not the case. It was really a wash. So our conclusions were there were no difference in disease-free survival. Despite dose titration, patients on the active treatment arms, in other words, we did have more retention of patients on study when we lowered the the dose, but really not very many patients actually dose escalated. And so if they started on the lower dose in general, the placebo patients dose escalated, but the patients on the active treatments, a smaller proportion of them dose escalated. And we did not see a difference in outcome in the landmark analysis. So then this last summer, about a year ago, this press release came out from Pfizer, and it was, boy, did I lose a lot of sleep over this. Wow, this is very different. It met its primary endpoint. So this data was presented at ESMO. And so this is a smaller industry trial. It's indeed a positive trial. This trial focused on patients who had a higher stage of disease, PT3 and higher. So ours had included PT1 and PT2 disease. And they limited it to clear cell renal cell. And they did not have a alteration in their dose. Everybody on this trial got 50 milligrams orally. They only allowed dose reductions down to 37.5. Our trial allowed dose reductions down to 25 for Sunitinib. And this was obviously a Sunitinib trial only versus placebo, 1-to-1 randomization. And their primary endpoint was independent central review. And you can see that the curves are separated here, and they stay separated. The hazard ratio was 0.76, and the p-value was 0.03. So clearly, this was a positive trial, showed some improvement in median disease-free survival, and they noted that at the 3-year, the DFS rate was 64.9%. At 5 years, it was 59.3 versus, so the curves kind of durably stayed separate. I didn't have the overall survival curve here, but the overall survival curve was not, did not show an improvement in overall survival, and I think people will be looking very closely at that. And the PROTECT trial will be presented at ASCO this year, and that is an adjuvant pazopanib versus placebo, and that is for patients that have PT2 and higher disease, clear cell predominant histology. So I think that we will learn a lot about these trials. There are other trials that are in development, including, or still haven't reported, including the MRC trial, which was done in Europe, which looks at a duration question as well of 3 years of sorafenib versus 1 year versus placebo. So why might one study be positive and the other two negative? So the PROTECT trial, there was a press release, and the PROTECT trial is a negative trial, but I think that you'll see some very interesting data with that trial. So was it the patient population? Was it the risk nomograms? Was it the dosing? Was it the central radiology review? Was it the statistical approach? So we went back and analyzed our data with ECOG 2805, and this was published in the Lancet this year, JAMA Oncology. So we had 1,943 patients who were registered on this trial. We excluded from this analysis 874 patients who had less than higher risk disease and other non-clear cell histology. So the patients that we went back and looked at were the 1,069 patients who had clear cell high risk disease. So these are patients with PT3, PT4, node positive, or N1 or N2 disease. And this is the number of patients randomized to Sunitinib, sorafenib, or placebo, all pretty well balanced. And so ultimately, we were looking at these three groups of patients. And when we adjusted for the DFS for PT3, T4, N1, looking at all comers, we still did not see any improvement in disease-free survival on our trials. So then, of course, the thing that everybody wants to look at is the dose. So what we did this a number of ways. We looked at starting dose. We looked at, and I'm only showing the dose quartiles. This paper went through many, many reviews. I think I got 5 pages of reviewer comments. Everybody was really upset about the dosing thing and wanted us to, we did many analyses, but ultimately what everybody agreed on is that we should look at a quartile dose analysis. So what we do is we calculate the entire dose of drug based on the patient's drug diaries and their and pill counts and things, and we divided the total dose of drug consumed by their 6-week cycle. So these are looking at quartiles over over the period of time that patients got the dosing, and you can see that this is the lowest dose of sunitinib. And this, so the people that got the absolute lowest dose really didn't, take very much drug. That curve is clearly separated. But when you look at the other doses all the way up to the ideal dose, they really don't separate at all. So we really don't think that dose has much to do on this trial with a negative result. And the same was true with sorafenib. Curve's a little bit wilder, but as you can see, they stay pretty much together, and we really don't think this is the highest quartile. So these are 25% of the patients got a lot of drug, and then so quartile 1 and quartile 2 in both of these should be what you would think of as the optimal dose. And you can see that there really isn't a big difference in outcome. It was not statistically significant. So one thing that people have pointed out about S-TRAC is just if you look at the number of censored events, this is the treatment arm versus the placebo arm, there are a lot of patients that are censored at the beginning. And so some of, statistically, it's sort of hard to know when you count patients how various statistical methods and stuff are counting patients. So it's possible that just the way that they were analyzing their data was so different than the way that we were analyzing our data. That could be a reason. But I suspect that it might also have to do more with genomics and the populations of patients that we enrolled. And so I don't think it's the higher risk disease. I don't think it's the starting dose differences. I don't think it's the clear cell histology. But I do think it could have something to do with how the patients were counted, or the pharmacokinetics or the pharmacodynamics. And one thing the PROTECT trial will tell us is the PROTECT trial did do pharmacokinetics in their patient population. So that data will be also presented at ASCO, and that's a very interesting poster that I'd encourage people to look at. So what I've done is, so here I have this negative trial, but this is really, we did a really great job of collecting tissue, and we have many unique blocks from patients. We have plasma, we have serum, we have urine, we have PBMC. So there's really, this is really a tremendous resource. And when you're designing a clinical trial, I think that you really want to talk to patients, and you want to be willing, you want to know what the patients are willing to do. Because if the patients aren't willing to do it, it's not going to get done. But you want to know what the patients want to do, so the patients have to be involved in helping to design the trials. But you also want as much as you can to learn as much, because you don't know whether that trial is going to be negative or positive at the end of the day. And this really has to do with, you want to do trials that answer simple questions, but you want to be able to learn as much as you can in the long run. And so the next few slides are just sort of highlights of kind of how we've leveraged this. So this is also going to be presented at ASCO. So Harriet Kluger from Yale wrote a grant, and she has a junior investigator now, Sarah Weiss, who I think got married this week, but she's really turned this project over to Sarah and one of her postdocs. And what they used is this automated qualitative analysis where they looked at slides. We made a tissue microarray of 200 patients from each arm with clear cell histology, and we looked at a variety of markers for angiogenic pathways. We're planning to go back and do this also with some of the immune markers as well. And one thing that clearly stood out was we looked at tissue microvessel density, and we showed that, so their poster is basically that high microvessel density was associated with a worse outcome. And so we're in the process of writing up this manuscript for review, but this will be at ASCO as well. And so then another thing that's come out of this is there was an RFA asking for cooperative group trials to be part of the clinical trial sequencing project. So this is a project that's being done under Lou Stout at the National Institute of Health, and it's sort of a mini TCGA. So ECOG 2805 has been accepted for that. They currently have the samples from 200 patients from each arm who are part of our clear cell population, and these are going to have whole exome sequencing, RNA-seq, DNA methylation analysis, and so if everybody gets on the same page about how we're going to count these patients and what our endpoints and stuff are going to be, we should very quickly have that information, and that information will ultimately be on the public domain, and people will be able to use it and leverage it just the same way that they are for the TCGA. So I think that this will be a really useful thing in the adjuvant setting, and I would argue that this is a better annotated sample collection because it's all within the context of one clinical trial, and so that's its real strength versus the TCGA. So Paul Cairns and Paul is at Fox Chase. Paul has built his career on promoter methylation. He's done some work with small renal masses, but we're hoping to leverage some of this and look at some differences that we see in gender and also in the papillary group of patients. So this is the DFS curve by gender, and this is already known that in general, women that have primary kidney cancer have a better outcome than men, but we saw this in this trial as well. And when you look at the DFS by gender and also by treatment arm, you can see that there are differences in, so we did lump it together whether they got sorafenib or sunitinib on this particular slide. The slides get too crazy when you split them all out, but you can see that men who got placebo were sort of down at the bottom of the curve here. Not much of a difference between drug and no drug. But when you look at the women, there does seem to be a trend that the women that weren't treated did the best, and the women that were exposed to either sorafenib or sunitinib actually it might have been somewhat harmful. So we thought that this was really good material to go back and analyze, and one of the things we're doing is going back and looking at serum estradiol and FSH levels and trying to kind of sort by menopausal status and see, because we also saw some differences less than age 56 versus greater than 56 as far as outcome. And there's some data in metastatic disease with toxicity with sunitinib also for women. So that's another area of interest of ours. And then this was, there was also an embedded cardiac sub-study. So I'm putting all this out, and I'm talking to the fellows here because there's really a lot of things you can do, you know, if you work with other people, and it's really a village to, you know, do these trials, but you shouldn't worry when you're writing a trial about, are you going to get all the credit? Because the more people that you enjoy, you know, that you invite and you talk with and invite to come along with for the ride, the more data that you're going to get out of it, because everybody has other ideas, and so, you know, when you're writing these trials, don't worry about talking to people, because generally people have good ideas and they're going to make you more successful in the long run. So our hypotheses with the cardiac sub-study, we're looking at MUGA scans in patients. They got them at baseline, they got them at 3 months, 6 months, and when they came off study. This was to fulfill an FDA requirement that Pfizer had, where they needed to show that these drugs had safety and cardiotoxicity, because in advanced disease, there's been papers showing as high as a 40% incidence and a decline in left ventricular ejection fraction in patients who are exposed primarily to sunitinib. So in our study, we showed only about a 4% difference. It was not really statistically significant. We didn't have a lot of events, but we do have all of these blood samples. So the other thing that we're doing that was funded by Kidney Cancer Association is looking at the biomarkers and specifically trying to, I think I have another slide. Yeah, look at PLGF and FLT1 and VEGF with regard to both hypertension and also cardiac dysfunction. So that's another area. Bonnie Key at Penn is working with Rupelbat at Harvard to basically tease out some of this data. Rupel took over that part of the SPORE when Mike Atkins moved down to Washington, D.C., and so she's been doing an in-depth cytokine analysis of patients on this trial. And so then I just, in the remaining time, I wanted to kind of shift gears and talk about some stuff that I've been doing at Penn and also some kind of harder to treat tumor groups. So one of the projects that we're in the process of putting together a manuscript for publication is that we did a sort of a homegrown trial based on some of Ravi Amiravati's data at Penn with autophagy. So Ravi is very interested in hydroxychloroquine, which is Plaquenil, and its effects in autophagy. And you know, it's recognized that everolimus is, you know, by its effects in metabolism and causing metabolic stress to patients to renal cell carcinoma, that combining hydroxychloroquine with everolimus might show an improvement in autophagy and lead to prolonged responses. And so I should mention that we also went back to the lab and we looked at cell lines and we looked at VHL mutant cell lines versus VHL wild type cell lines, and we tried to stress them with both rapamycin and hydroxychloroquine, and we really did not see a difference in this. And so our conclusion, at least in the lab, and we did this sort of after this trial was up and running, you know, we really weren't impressed with what we saw, and we thought that the VHL mutant ones, you know, that there might have actually been kind of a protective effect. So we were looking forward at this trial and kind of wondering, well, what are we going to see in the patients? And so this is a busy slide, but I just wanted to show you what hydroxychloroquine's role is, and that's in inhibiting fusion of the lysosomes, which is an important part of autophagy. And hydroxychloroquine is really a very well-tolerated drug. It's cheap, so it's really easy to do a clinical trial with this. And he's done a number of combinations. They're doing this in pancreatic cancer with gemcitabine and Abraxane. They're doing this in melanoma with BRAF inhibitors. And he's now starting to look at this in combination with some of the immune checkpoint inhibitors. So what we did in this phase 1/2 is we teamed up with the University of Pittsburgh, with Len Appelman, and with Mark Stein at Cancer Institute of New Jersey. And we did a phase 1, phase 2. We had 2 doses that we planned to go. One was hydroxychloroquine 400 milligrams twice daily. The other one was 600 twice daily with full dose of everolimus, which is also approved for use in metastatic kidney cancer. And we included patients that had received up to 1 to 3 prior regimens. We kind of based this on the record data, and what we wanted to do was to beat record 1 and show that we had an improvement in progression-free survival in this population. So it was completely tolerable. We got through the phase 1 phase in 6 patients, and our treating dose was the full dose of hydroxychloroquine with everolimus. And so this was our patient population, and you can see that it was pretty similar to the record one population. Most of the patients were pretty healthy, and that we did meet our primary endpoint. Oh dear, the slide didn't change. So let's see. Oh, you know what? It did change. I just needed to get rid of so far. So we had 15 patients out of a total of 38 patients evaluable who met their stable disease endpoint of greater than 6 months. We had 2 patients with partial response. We had 5 patients who had non-grade 3 toxicity. They just had intolerability of the everolimus. There was a lead-in, I should say, of 1 week of everolimus before they started the hydroxychloroquine. And these 5 patients in the first week had fatigue and kind of the blahs that sometimes people get with everolimus, and they said, nope, we're not doing this. And so that's we didn't call them grade 3, but we did exclude them from the efficacy analysis. Had 11 patients with progressive disease, and the total number of patients with stable disease was 22. So we really had a pretty good return. And I guess what I'd like to emphasize is that we really had very little in the way of grade 3 toxicity. So is this, you know, I think the conclusion of this is that we did see durable responses. It's a very tolerable regimen. We just did whole exome sequencing of these patients, and Ravi's busy putting that part of it together, so I don't know that I can really comment that we've seen a correlation. We were looking for, you know, obviously TSC1 mutations, for TOR mutations, for things like that, but we're still putting that data together. So the unfortunate thing, of course, is while we did this, that Lenvima and everolimus was approved based on randomized phase 2 for treatment of renal cell, and so I do not think that this combination is going to go forward into a bigger trial, but you know, it's still a reasonable regimen to consider because you know, we now have phase 1, phase 2 data on this, and we know that it's a reasonably safe regimen to offer patients. So if there's patients that are appropriate for everolimus, and I would say that patient population tends to be, you know, now in the era of genomics, and we have garden assay, and we have other things that we can look at. If the patient seems like an appropriate patient to get everolimus, so those would be patients that you knew had this mutation, or patients that were not appropriate for either a VEGF inhibitor, you know, because of toxicity or other reasons, or were not appropriate for an immune checkpoint inhibitor. So I have 1 patient that I've been treating on this regimen who has very bad psoriatic arthritis. And she was on Humira before she went on this. We took her off the Humira, and we put her on the hydroxychloroquine, and all of her symptoms went away. It did a better job of controlling it than the Humira had done. And she's been on this now for three years. She has liver mets, but she really didn't tolerate a lot of the tyrosine kinase inhibitors. And she just recently started to progress, and so we added Lenvima in, but she wants to stay on the Plaquenil because it's really helping with her symptoms. So I would just say, you know, this is, you know, if we'd done this quickly and we'd done this, you know, 5 years earlier, then maybe it would have been something that could have gone on to a phase 3. But the world of renal is very crowded now. So what about immunotherapy? So this is the nivolumab Kaplan-Meier curve versus everolimus that Bob Motzer published in New England Journal of Medicine in 2015, and you know, there was an improvement in median overall survival. So now we're where we were with the VEGF TKIs 10 years ago, and now, guess what? Now all the adjuvant trials are starting in this. So the same opportunities really exist for the immune checkpoint inhibitors as were for the VEGF tyrosine kinase inhibitors. So in renal, where it's a little bit harder to tease out, you know, who's responding and who isn't responding. You know, clearly in non-small cell lung cancer, we know that you can look at the PD-L1 expression, and you can know that the patients that have that expression are more likely to benefit from these drugs, and that paradigm does not seem to be bearing out in kidney cancer. So is it the inflammatory profiles that that Wayne is interested in, and and are there other things that we can quickly tease out as reasons? Is it the bad disease? Clearly, sarcomatoid renal cell tumors seem to respond well to these regimens. Patients with very aggressive disease sometimes do, but not everybody responds to this. And so, is it going to be the combinations of dual immune checkpoint inhibition that work? Is VEGF still such an important part of this? Seems to be that we should be either sequencing these, alternating them or using them in combination. So we're back to the same thing where, we're looking at the same things we were looking at with tyrosine kinase inhibitors, trying to tease out the populations. I think that epigenetics are a very missed opportunity still in a variety of cancers, and especially with all the epigenetic gene modifications that we see in RCC. Should we be doing more things in combination with those? And then the last few minutes, I just wanted to focus on, this is the 20% of patients, and the same thing, don't respond to anything. And these are patients also that, some of these patients that responded to immune checkpoint and didn't respond to VEGF TKIs, but there are patients still that don't respond to any of these drugs. They just roar through VEGF TKIs, they roar through immune checkpoint inhibitors. So really understanding that population and what to do about it, this is really an area that the industry is busy focusing kind of on the low-hanging fruit, but these are real opportunities for people to get together and study these and learn about these. These are things that young investigators can write trials and learn a lot. So one thing that we did was, so these are various ways that you can approach these populations. You can approach them by grouping them together and using therapeutic ones. You can do molecular profiling. I think that we're almost to the point now where we can use some of the tools, not as biomarkers in renal, but we can certainly use these to classify, before they start treatment. But this was one trial that we did that Bradley Carthage was part of the, it's on me to finish getting the manuscript together. I'm still looking at the case report forms. But this was an ECOG trial that Emory did, in large part, did a lot of accrual to this trial. And this was presented last year at ASCO. And this was looking at a question of whether patients who had sarcomatoid features, we'd previously done a trial in ECOG looking at adriamycin and gemcitabine based on some smaller studies that seemed to show that in these very rapidly proliferating tumors that using chemotherapy actually got control of disease. And there were some durable responses in that population, but it's a very toxic regimen. I mean, there's a limit to how much adriamycin you can give. That was 50 milligrams per meter squared of adria every 2 weeks with gemcitabine. The gemcitabine is 1,500 milligrams per meter squared IV. So, you get in a number of doses, you get control of the disease, but you can't keep people on that regimen forever. And so Dror Michelson up at Mass General had been looking at a phase 1, giving Sunitinib with gemcitabine. And so we wanted to take this to the cooperative group, move that question farther forward. We did a lot of agonizing about, well, which is the more active drug? Is it the adria? Is it the gem? But adria is just way too toxic to give with Sunitinib, and so we settled on a combination of Sunitinib and gemcitabine. But look at this. So I don't have the dosing in here, but the gemcitabine, we had to get at, we couldn't give it at 1,500 milligrams per meter squared. We had to give it at 1,250. That was the highest dose we can give. And look, we had to give the Sunitinib at a reduced dose as well, because there was just too much toxicity in the phase 1. So this was the chosen phase 2 dose for this randomized phase 2. And then the control arm, what we did is we used the regimen that we all think people should be using for sunitinib, but that Pfizer has sort of never moved forward. And that's the 50 milligrams, giving it 2 weeks on, 1 week off, which is a way more tolerable regimen for most patients. Most patients just can't get through that whole 4 weeks of sunitinib before they have to take a break. So we used a dose-intense cycle. We did this. We allowed patients who had any percentage of sarcomatoid features. We did stratify based on whether they had less than or greater than 20% sarcomatoid features, whether it was clear cell or non-clear cell. And we did allow them to have prior mTOR therapy and kept track of that as well. And we had 3 risk categories. We had less than 20% sarcomatoid features were good risk, 20 to 50% were intermediate risk, and greater than 50% were poor risk. And then along with that, if they had a performance status that was 1 or greater, that also pulled them down to the risk category. So this is looking at the population, how many people were treated, the arm that got sunitinib and gemcitabine. Most of the patients on this trial were still clear cell. There were a number of unclassified patients who were mixed histology. There were very few patients that had papillary histology that were enrolled. But by and far, you still had quite a few people that had relatively less sarcomatoid features. So we thought that we were going to see something in this trial, but it was really kind of a disappointment. So I tried to fix this slide. I apologize. I don't know how the stable disease got down here, but stable disease is down here, and I couldn't fix it on my Mac last night. So you can see that in the sunitinib gem arm, there was a higher response rate in the patients who had the sunitinib gemcitabine, but their median PFS was longer than the patients that were on sunitinib, but really didn't. The sunitinib patients ended up living longer, and look at the number of cycles patients were able to tolerate. I mean, that's terrible. There were only most of these patients just got about 3 cycles and then blew through. So this is a really bad population of patients that's really sick. And, we're still trying to kind of tease through what all happened here. But this is these prognostic groups, and this is the number of patients that were treated. This is a little bit confusing slide. So we had this is the number of responses that we got in each of these groups, and the number of patients that were enrolled on each of these groups. So we're going back and looking at these, and there were some patients talking to patients at centers. Ted Logan at Indiana University had somebody that had an incredible response and is still on this and was on it for at least 2 years, but we sure had a lot of patients that just really fell apart on this regimen. So I think that it would be impossible to kind of go back and use this as a control arm, I think, with the immune checkpoint inhibitor therapy. But I think that there are great opportunities, maybe when industry settles down a little bit, to go on and to look at this population of patients, with some more informative biomarkers and stuff. This was our PFS curve, and as you can see, that ultimately, even though there were more responses in the Sutent Gem group, the sunitinib group ended up living longer. So I'm not sure what that shows, but we did see a lot of toxicity, and I think the other take-home message is, with we weren't able to get a full dose of gemcitabine into these patients. We weren't able to get a full dose of sunitinib. And so maybe the dose intensity, does make a difference, and you're compromising it by combining 2 drugs together. So this was not the drug combination to use in this population. So our conclusions were the doses were limited by toxicity, and the population of patients, again, was defined by morphology and not by genomics, and there was a lot of toxicity. So then lastly, what we've done at our own institution is just taken the opportunity since nivolumab got approved. We had a very nice honeymoon phase of about 6 months before everybody out in the community started treating people. So we treated patients. So we're still collecting. We have about 25 patients now. But these were patients who've had multiple lines of therapy, and they were going on nivolumab. And we made the observation that there were a number of patients that were improving clinically on this. And so we took the opportunity to bank a bunch of information. We started collecting blood prospectively for exosome analysis, which we're doing in collaboration with David Isidore at Penn, who has a high throughput microfluidic chip-based system. We're also collecting with EPIC's system, which is a circulating tumor platform where you draw blood and you put it on slides, and the program counts every slide. So you have the opportunity to look at cells that aren't just collapsed or collected by EpCAM, by epithelial markers. A lot of renal cell has mesenchymal markers and stuff. So we're looking at that. And then we're also doing a T-cell exhaustion assay in collaboration with John Wherry, who has this interest at the University of Pennsylvania. And so these are some preliminary results in the first 10 patients from EPIC. It's expensive, so we're doing this with philanthropy. But the main thing that I wanted to just show here is that we are able to collect circulating tumor cells in this population, and we are able to measure PD-L1 expression in the circulating tumor cells on the EPIC platform. So we think that this will be useful information prospectively to look at, and you can also look at interactions with cells. So you can see on the EPIC platform when cells are sort of sticking together, and so then you can go back and do exome sequencing and maybe understand the interactions of these cells. So we think that this is ultimately going to be a useful platform to look at in renal cell. And then Alex Wang, who is just about to become an attending at Penn, has been working tirelessly in John Wherry's lab. And he just got this paper published in Nature about a month ago, looking at this population in melanoma. And so, one of the things that, one of the reasons that we think that, and this is pretty well known now out in the community, people have been looking at this in a variety of solid tumors, but that these T cells have this functional memory, but that after a while they sort of, become exhausted, they don't work as well, they stop being effective, and so what can you do to kind of reinvigorate T cells? So what we're doing is we're collecting this. We're collecting these every 2 weeks in patients that are on nivolumab for the first 3 months or so, and then at 6 months, and then going forward. And we were valuable to John Wherry's lab because he was doing it in melanoma, and they were using pembrolizumab, and he was getting the markers at 3 weeks. And I said, well, how do you know that you aren't seeing it at 2 weeks? And so that was our in to look at it in nivolumab, because our patients are having to come in every 2 weeks for nivolumab infusion. So we're prospectively collecting this, and this is some of his data with melanoma, and we think that basically tumor burden is probably going to be pretty important as far as, if you have a lower tumor burden, these T cells, these immune checkpoint inhibitors may work better too, because there's less to exhaust the T cell. And so my final slide is just basically, or my second to last slide is just, we're now leveraging this opportunity in the to look at immune checkpoint inhibitors in the cooperative group, and this is Lauren Harshman is the study chair of this. This is the new PROSPER trial that we hope you guys will open or are opening here at Emory. And this answers a very important question. So there are going to be 3 or 4 immune checkpoint inhibitor trials in renal. This is the only neoadjuvant trial. And so this is answering a very important question of, do you need the intact primary tumor in there to kind of prime the T cells and to help T cell memory? Or if you take out the tumor, does adjuvant therapy work as well? So we originally designed this as a 3-arm trial where patients would either get preoperative nivolumab for 2 cycles, followed by resection, followed by 9 months of nivolumab therapy. We have an observation arm here where patients just undergo resection of the primary tumor, followed by observation. But we'd hope to have an adjuvant arm as well, and people were very reluctant to have 3 arms. They thought it would be a very hard sell for patients. As it is, we are doing this as a 2-arm study. We also were limited by CTEP to keeping the trial under 1,000 patients, and so we had to be somewhat creative. You'd need a much bigger trial to do this as a 3-arm trial. So hopefully we can answer the question of whether this neoadjuvant approach is more important than the adjuvant approach, and industry is rushing forward to do 2 adjuvant trials. There's an adjuvant atezolizumab trial that is currently accruing, and then Merck is on the verge of opening an adjuvant pembrolizumab trial. So I think when it's all said and done, we will learn a lot about the role of immune checkpoint inhibitors in the adjuvant setting. And it's an exciting time for renal cell, but I would also just want to convey that these opportunities are, open in any kind of disease, and you can do what I did also. I mean, I don't often have the volume of patients at my institution to, we're not an MD Anderson, we're not a Memorial, but if you get involved in the cooperative groups, you can do these sorts of things, and it can really leverage your career. So I'll thank you for inviting me, and happy to answer any questions.